All right, we're gonna get started. Please remember to put your names in the chat so we can log your virtual attendance. It can happen anytime throughout the talk, so no worries if you forget right now. We'll go ahead and get started. So this is our Q3 quarterly update. Thanks for joining us, whether in real time or on video afterwards. A couple updates for the field. So one question we had recently was about pink sheets and MCOTs. So you guys know what a pink sheet is? Awesome. Yeah. So technically, it's an application for emergency admission. What that means is this person has been deemed to be a danger to themselves or others, or unable to care for themselves, and so their rights are taken away. And this application allows them to be transported to a medical facility or psychiatric facility for evaluation. You guys know who can place a pink sheet? Who can place a pink sheet?
Oh, MCOT.
MCOT, yeah. Law enforcement, any physician in the state, psychiatrists or physicians, or a designated mental health provider like an MCOT person. So once a person's pink sheeted, that means that's kind of their ticket to ride for transport to a facility, whether they want to go or not. One misconception that I had myself, and I think that was out there in the field, was that the person who places the pink sheet has to accompany the patient to the ER. I think that came from the fact that often law enforcement is placing the pink sheet, and generally, if law enforcement is placing a pink sheet, that person is not safe to be transported, and so they're either going with that law enforcement officer or the officer is following us to the hospital. The truth is, the pink sheet puts them in law enforcement custody, but the person who places it doesn't necessarily have to transport them with them. So if that's a psychiatrist, a transferring physician from a facility, or an MCOT person, that psychiatric health provider doesn't have to transport with them, just the law enforcement officer. If they don't meet the medical criteria or the state criteria for a medical patient, and that's basically anyone who may potentially or obviously need medical monitoring or transport, they can go with the police. The police can transport them in their cruiser. They don't have to go in an ambulance. But if they meet the definition of a patient, then we transport them in an ambulance with law enforcement if needed for security. But yeah, MCOT, they do a great job. They're overworked and probably underpaid. But they don't necessarily need to go to the hospital. So misconception on my part, and I think it's kind of been out in the field for a while. Any questions about that?
So we ran into that at a previous call on a shift I was on a while back. And if I remember correctly, back the pink sheet stated something along the lines of whoever issues the pink sheet is
respond to chest pain at 40, 656 South Pass Drive.
It's not the case. Can you kind of clear that up a little bit?
I will have to.
Kind of contradictory from what the sheet says, at least from what I remember.
Yeah, I'll have to. Let me go back and actually get my hands on one of those again. When my next shift, I'll take a look because I haven't looked at it that closely on the back. This, what you're looking at right here, is the state's. I forget if it's a statute or a rule or what the actual term for it is, but this is the language from actual legislature, a law. Thanks, Rob. And what it might say on the pink sheet is that the responsible party has to go, and technically that's law enforcement. So once they're pink sheeted, they're by definition in law enforcement custody. So I wonder if that's what it's referring to, but I'll take a look at that and get back to you. All right, another update, medication update. Sorry to adjust the dosing for ketamine one more time. This is really just a typo that we caught in our review. So we had an issue with the weight-based dosing, the ideal body weight dosing for the large and extra large doses of ketamine. That's been adjusted here. So no real change in treatment. We're very rarely, if ever, using that extra large dose, but we just decreased the height statute and specified the weight for that large dose there. Another great question that came up from the field was why we use ideal body weight to dose ketamine. If you look at some references, it'll recommend using actual body weight, which is actually definitely accurate, but really up to a BMI of 30. And beyond that BMI, once you get heavier, then you get more risk for the adverse effects of ketamine when you're giving those higher doses. And because most of our patients have a BMI above 30, most of us have a BMI over 30, this is just a way to make sure we're staying in a really safe range. Another thing you'll notice, if you go and plug these numbers into an ideal body weight calculator, you might get different numbers. In fact, you probably will. And that's because there are about 6 or 7 different major formulas we use for ideal body weight. And it also varies based on gender and a couple other issues. And so what we've done is to try to simplify it as much as possible. It's basically an average of a lot of those formulas, and just made sure that this keeps us in a really safe range, both like physiologically and also more kind of politically and what the hospitals are going to balk at. So it's still very effective dosing, but that's where all this dosing comes from. And so sorry for the tweaking again. All right, getting into part one of the update, the kind of major part. Have you guys heard about First Pass yet? First Watch? All right, so we had a questions for the chief where we addressed this a bit, but this is part of our evolution of our continuous quality improvement process. And so First Pass is a subset of a bigger software called First Watch. And how we're going to start applying this going forward is there's a little bit of background of how we do case review right now. So we have a case, sick patient. We review that case. We one at a time. We then look at individual crew and provider performance. We say, did they meet all the metrics? Are you getting EKG in time, aspirin on board, things like that? And if we identify an area for education or improvement or questions to ask, we come and do a case review with you guys or shoot you a message on ESO. And oftentimes it's just like, hey, great job. And just look at, or, condolences for a tough case, or sometimes like, hey, just a couple of things to think about. And over time, as we look at cases, we kind of get a better sense of how the system is performing. Hey, we've seen 10 chest pain cases that went great. I think we're in a good spot. Or we've seen 100 that didn't look so good. We need to work on time to EKG, whatever it is. And that's how we kind of choose our educational pushes and performance improvement plans for the system. As you can imagine, we get a lot of cases. So all those cases get basically put on the EMS division to sort through and figure out which ones to pick, even review, because we've got 35,000 calls a year. So that boils down to 600 to 700 cases a week. And it's just impossible for us to look at all those cases. So we pick cases based on like high risk, low occurrence events like chest tubes or pediatric arrests. I look at all cardiac arrests and STEMIs, things like that. But obviously, we can't look at everything, and things are going to slip through the cracks. Where First Pass comes in is it's a computer and a program, and it does what computer programs do best. It sorts through data. So we set a bunch of tests and criteria and say, hey, we want to review all these calls for these metrics. And that comes from the EPCR, it comes from dispatch. And we want to know which ones we should actually look at. And because the vast majority of calls are fine and there's no issues. So what it does is it passes all these calls, all our calls through these tests. And then we can say, hey, the small subset didn't meet that criteria. And then that small subset is what we know to look through as human reviewers. Often we've started doing this just to practice and get through the system. We're still refining it. We've already found that a lot of those calls where something wasn't right are just either a typo or a patient didn't receive aspirin because they objected to it on a religious basis or whatever. And the care is totally fine. It was just because there was an exception why it kind of got flagged for us. So we'll say, hey, that one's fine, no worries. And then we can move on and really focus on those cases where we actually saw an issue that needed to be addressed. And whether that's education for the crew or an individual provider, or there's a systems error, like, oh, our protocol is wrong here, we need to address that. That's where we come up with the changes we have to make. And so over time, week to week to week, we're able to really focus our attention on the cases that actually matter and not spend a ton of time spinning our wheels, just filtering through cases. And then we can apply those cases over time to look at the system as a whole. And we've shown you guys charts like this from ESO that are similar, but those charts just have a ton of noise because there's so many other cases that we don't really need to look at. So now these charts are going to be even a bit more, actually much more specific and accurate in terms of how the system's performing. One thing that First Pass will also give you is something called an employee scorecard. And I really hate that term because that's not what this is for. And I've asked them to actually change it or come up with something different, because this isn't about scoring you, isn't about grading you. This is about personalized feedback for yourselves and how you're performing. So this is like the summary form. This is the more drilled down version of it for like really deep, kind of more minutia detail. We can pick whatever we want to incorporate to send you guys. Some of this will be operational. You can see like shoot time up there, total scene time, stuff like that.
You're no longer just like a hungry Buddhist. You're like, this guy's
Don't forget to mute if you're out there. So you can see that some of the, and then this summary page will also include like, hey, how are you performing overall on some major protocol buckets that we're looking at? So chest pain, seizures, pediatric arrest, things like that. And then you can drill down to like actual, individual interventions and performance and get a sense. The point of this is that it is all automated. No one is sitting there tabulating your score each week and keeping track of, oh, you got a 98 this time and a 96, like you slipped 2%. we
Right.
love you in the EMS division, we care about you, but we do not care about you that much. We just don't have that time to devote to every single person. If so, this is going to come out. We'll figure out the timing that makes the most sense for the system, whether like monthly or quarterly, but it really is just a sense for you to get a benchmark, understand how you and your crew are performing within the system. No worries. Again, if you're out there, make sure you're all muted. Thanks. So know how you're performing within the system, and then you can come to us and say, hey, like I've noticed this is an issue. And honestly, I bet the majority of the time it's going to be a data entry issue or something on our end that we need to tweak. But it just kind of helps to identify that. If we're reviewing cases and they're like over and over the same name or crew shows up, then we can use those individualized records to go and look and say, hey, is there an issue here? And then again, help to targeted education and support. It is not meant to be punitive. That's not the point of it at all. I just don't want, I hate, that's why I hate that idea of it being called a scorecard. So if you have any questions about that, let me know. I know it can be both helpful and stressful to get metrics like that, but the idea is to make it as supportive and helpful as possible. So we definitely appreciate your feedback as we implement this new system. Any questions about that? Okay, part 2, Droperidol. So we're adding another medication to the toolbox, and Dr. McNeely hit this on the last quarterly update, but we're going to go live with it, so I just wanted to hit it one more time. So Droperidol is actually an antipsychotic medication, but it's got other effects. It's a sedative, it's an antiemetic, meaning it helps with nausea and vomiting, and it has some anxiolytic and, again, kind of sedative properties and antipsychotic properties, because that's what it's really made for. It is an amazing medication for nausea and vomiting, and actually abdominal pain and migraines as well. And it's also very good for agitation, especially with behavioral emergency. For adults, the dose for nausea and vomiting is 0.625 milligrams. You can repeat that in 15 minutes, and that can be any route, IV, IO, or IM. And for behavioral emergency, it's 5 mg IM. It's fast onset. It's got a quick peak, and it lasts for a few hours. It is a very effective medication that we use all the time in the ER, and it's gaining traction again. Some of the side effects, you can get something called akaesthesia. Do you guys know what that is? It's when people, have you ever given someone Reglan and they start just getting really uncomfortable or jittery? That's that akaesthesia. Some people talk about it like their skin's crawling, or they just get really anxious. They like want to get up, get out, and start moving around. That's pretty common with all of these dopaminergic antipsychotic medications, and definitely a common effect that we see with Droperidol, like Reglan or other meds. It also can prolong your QT, so we have to be careful about that, and not surprisingly, it's a sedative. Droperidol, if you talk to like older ER docs, or maybe even older paramedics, they loved this back in the 90s. They thought it was this miracle drug that treated migraine and nausea and vomiting and it was awesome. But then it got black boxed, and so it disappeared in 2001. So, but with some new studies, just like everything from the 90s, it's all coming back. So like we use this, I mean, I think between ketamine and Droperidol, these are like 2 of the most used medications in the ER these days. The evidence we use for it. So again, it got black boxed. Oh.
Division 101 and medic ambulance 43.
Yes.
Problem.
Cool.
514 West Meadowbrook Expressway. Respond on bed fire 2 near 3900 South. Medic engine 101 and medic ambulance 43. Respond to diabetic problem at 514 West Meadowbrook Expressway. Respond on bed fire 2 near 3900 South. Time out 1318.
All right.
Respond to diabetic problem at 514.
So it fell out of favor in 2001. We'll let that go too. So yeah, fell out of favor in the early 2000s because it was causing cardiac dysrhythmias, or was found to cause that. But in the cases they reviewed, they were giving 20 to 200 times the dose that we're giving now modernly. So a ton of evidence has come back out showing that Droperidol is, one, very safe in the emergency department and in the pre-hospital setting for these indications for behavioral emergency and for nausea and vomiting. It's been compared. One of these studies looked at 6 trials, put them together, and compared its efficacy to Reglan and Midazolam and Zofran. It's actually the only one that was significantly more effective at treating nausea across all those medications, and it's at least as effective if not more effective, for treating active nausea and vomiting. It's also faster onset than Haldol for behavioral emergency and had a safer profile. So for all these reasons, we've opted to replace 2 medications with 1. We barely use Haldol in the system as it is. And obviously we do still use a good amount of Reglan, but the nice thing about Droperidol is that it is equally effective and fast acting, whether you give it IM, IO, or IV. So there's no more IV piggyback or slow push. It's just an easy to administer medication. It's got a great safety profile and it's really effective. And unlike Reglan, when you're giving it for nausea, vomiting, and abdominal pain, it's actually really effective at treating that abdominal pain as well. So it is a medication that we've all come to really know and love in the ER. And it does a good job of treating that kind of more vague abdominal discomfort and pain as well. So we'll be going live with this medication. Here's our protocol. The dose is kind of as already described. It's going to be second line still for behavioral emergency after ketamine. Ketamine is just working really well for us. We've had no adverse events really from ketamine. And the problem with the one, not even problem, but thing to keep in mind with Droperidol at that higher IM dose is that it can cause some hypotension, which is why it's not first line for us. So for those 2 reasons. You'll notice that the cautions and adverse effects sections are disproportionately large compared to some of our other medications. That's really more just because it's a newer medication. I want people to read about it, understand it a bit. None of the contraindications are what they are. These cautions aren't hard contraindications, obviously, but just while we get more familiar with it. If people have some of that akaesthesia, that irritability, you can treat with Benadryl that can help blunt that a bit. Although there's not great data to support that, a lot of us still do it. The big things to remember are no kids, no pregnancy yet, and to watch for QTC prolongations. If they have a history of that or pregnant, or you see it on the monitor, then we want to hold off. But same with Reglan and Haldol.
Hey, T, had a question.
Yeah.
Dosages for migraine headaches.
So it has not been validated in the pre-hospital setting for migraine headaches yet. I was thinking about that as I was writing this up. So we're going to start with nausea, vomiting. Part of the problem with treating migraine headaches aggressively in the pre-hospital setting is we don't have CT scanners. We don't have ways to rule out other badness. And there's some concern amongst leadership in EMS that we don't want to be too aggressive at treating headache in the field with medications like this because we don't want to then miss concerning signs or symptoms in the ER. I've got my own feelings about that, but I think it's fair to start with these 2 indications and then kind of expand as we go. All right, part 3, we're going to get into a case review. Just a reminder that the point of case review is educational and supportive. This is a safe venue for us to ask questions, discuss cases. This is protected and confidential, so good or bad, don't discuss case review details outside of this forum. It's a little funky when it gets into virtual and you're watching it later, but this is the general kind of spirit of the case. Case we're going to review today was submitted by one of our crews who did an awesome job, but this is what they were called out to. So they're dispatched to a full arrest for an 18-year-old male. When they show up, as they're getting their assessment, the history they get is this guy was working at a construction site. He was actually up at an elevated platform and hadn't been seen for a while, but I think someone did see him kind of lay down at one point, but then he hadn't been heard of. Someone got up there and realized he was still down and unresponsive. They lowered him down to the ground. He didn't have a trauma, no fall, but when EMS arrives, our crew noted that he was unresponsive. But when they use verbal and tactile stimulus, he would just moan incomprehensibly. They weren't able to get much of a history, and this was a few weeks back now, and these are the first vital signs they got. So, profoundly hypotensive, tachycardic, altered. Any other information you guys want here? They weren't sure about that first pressure. Again, this is like an 18-year-old male, so they checked it again. Yeah, those pressures and heart rate are definitely real. And they got a temp. He was 107. So yeah, pretty significant. So with that, with those vitals, what do you want to assess next? What do you think you might find in your assessment? Yeah, you're looking at the rest of your patient.
Look like this kind of, is his skin, and seems like, is he still sweating? Is he stopped sweating? Is he going beyond?
Love it. Yeah, we know he's unresponsive. And now is he, and I love the sweating question. What are you thinking about with sweating or not sweating?
if he stops sweating, right, he's gone past the point of the, man, words are coming today, but past the exhaustion and he's going into heat stroke.
Love it. Exactly.
Shut down his organs.
Yeah, he's no longer doing, his body's not doing what it's supposed to do anymore, right? So, and they crew did a great job with their assessment. They did multiple assessments, but they noticed he was not just unresponsive, but he was hot and dry, which is super concerning. And they recognized that immediately, recognized this is probably heat stroke. So
How long?
they did not, I mean, he hadn't been, I'll have to ask the crew again, but I know it had been a matter of time. So it wasn't just like 2 or 5 minutes. It had been, 30, maybe 40 minutes. I think someone had seen him, but I'd have to check in with them about that exact time frame. So they recognize this is probably heat stroke and they don't mess around. Within 4 minutes of patient contact, they're transporting. Within 2 minutes of getting him in the ambulance, they have an IV, they start fluids. And within 2 minutes of that, they started cooling measures and they've got him on monitor and getting a rhythm. Another minute later, he gets another IV. And by that time, they didn't really have a whole lot of time to get other interventions going, but he's at the trauma bay. So 20 minutes from point of contact to walk into the trauma bay, which is pretty fantastic. This kid was still 107, I believe 108, even when he arrived at the trauma bay. He was, as you can imagine, immediately intubated, cooled, and sent to the ICU. And testament to young age, he had a couple days in the ICU, extubated, and had a full neurologic recovery. So did great. No end organ damage, no evidence of neurologic deficit, which is pretty wild, but definitely in no small part thanks to the crew acting quickly and getting him transported quickly. And we'll kind of talk about why. Okay, so heat illness. Our body has 4 major mechanisms by which we transfer heat, whether we absorb or dissipate heat. So radiation is, do you guys know the difference between these or a little bit? I'm guessing depending on your training, you probably heard of these before or just living in the environment that we do. So radiation is when we lose heat to the environment through electromagnetic waves. So different than conduction or convection, this is like kind of how heat from the sun gets to our planet. It's those electromagnetic waves that carry that energy either away or to our body. Conduction is when you have direct transfer by direct contact. So like this statue sitting on the stone, that heat transfer between 2 solid objects is conductive heat transfer. Convection is when a liquid or gas moves across our skin and removes radiated heat from our body. And that's typically air or water, but technically it could be any gas or medium that you're exposed to. And then evaporation, and that's heat loss by evaporation of water from our body or sweat. So when we're in a temperature that's colder than our body temperature, then radiation is the major mechanism by which we lose heat. That's one of the reasons that wearing clothing, insulating clothing, is one of the best ways to maintain heat because it prevents that radiation. And it's, they've got those like the silver line coats and everything that are supposed to maximize reflection radiation. Back out again.
Engine 101 and medic ambulance 41. Respond to heat or cold exposure.
Oh, sweet. It's gonna be perfect. Man, I should go with you guys. We have a GoPro. Yeah.
21.
Heat or cold?
South. Respond on deck fire 2. Timeout 1328. Exposure. S221. West 2100. South. Respond on
What's the second recording for? What's the repeat recording for?
To the other station.
Oh, it's on the radio. Got it. Okay, so when we're on our bodies in a hot environment, hotter than our core temperature, then evaporation becomes the most efficient way by which we cool ourselves. And we use evaporative heat loss both through the lungs and the skin. So actually respiration is a major source of heat dissipation and heat loss when we're really hot. Another one reason that we breathe so hard when we are recreating. Once you start sweating, we really take advantage of evaporative heat loss. And sweat is pretty impressive. When you sweat at a moderate amount, which is about 1 liter an hour, that dissipates up to 300 kilocalories of heat. So to put that in perspective, that's how much energy it takes to run 3 miles or how much energy it takes to boil 3 liters of water. So it's a lot of energy. Problem with sweating is while it's really effective, as we all know, it also can lead to dehydration and electrolyte losses. So you have to be really conscious of that based on how much someone's sweating. Do you guys know of any other responses our body does to heat? I've only got 2 people here, so sorry to put you on the spot. Nice. Yeah, so vasodilation is one of them. And what happens there is that a doorbell?
No.
Says Droperidol.
Okay. Vasodilation is when it's dilation of the blood vessels, and this happens mostly at the surface area of our skin, at those capillaries. And what this does is, by dilating those blood vessels, it increases surface area for radiative heat loss. But more importantly, it allows for more fluid transfer to the skin and more fluid loss through sweat production. Any other, getting a little more biomechanical here, biophysiologic here, but we also increase more stress hormones and activate our sympathetic nervous system that both activates sweat glands and also increases heart rate and cardiac output. We can, between vasodilation and cardiac output increases, we can actually increase the amount of fluid that runs past the surface of our skin by up to 4 liters per minute. So pretty dramatic increases in that heat transference and fluid loss. And finally, our hypothalamus actually tells us to stop and slow down our metabolism to decrease heat production. So one reason that you're excessively tired and more easily wiped when you're out in the sun is because your body is literally telling you to slow down, chill out. It's trying to be protective and decrease the heat that we just naturally produce through metabolism. When we add wind chill to convection and evaporation, we can up to double the amount of heat loss when we're sweating. So if you have a good breeze and you're sweating heavily, you can dissipate up to like 600 kilocalories per hour. So really effective way to take advantage of that evaporative heat loss is to add some moving air, which we'll talk about. As we were discussing, heat illness occurs when our body's mechanisms to cool us naturally actually fail and get overwhelmed. Have you guys ever read like Born to Run? No, it was like, again, another thing big in the 90s, I think, or early 2000s. Anyway, it's this book about barefoot running, but one of the theories about how humans developed is that we are endurance athletes, and unlike other animals that have heat, or excuse me, have fur and other ways to maintain their heat, we have this incredible ability to sweat over long distances. And so we would literally run animals to death because we can maintain a normal thermic body temperature and exertion level over time that other animals can't. That, of course, goes to a point, and when we get past that point, we're unable to increase heat production or compensate for that. We can't stop excessive heat loss, or we can't protect against this external heat gain. So that's when our body becomes overwhelmed and we slip from kind of heat exposure into heat illness. Dehydration and electrolyte losses can also make that worse, as can a few other risk factors. Anybody you think about is more at risk for heat illness? Young and elderly? Awesome. Yeah, so extremes of age. These are all going to come up in different order, so I'll just put them all out there. So extremes of age down there on the left. Anyone with known heart disease, if they can't vasodilate and increase that cardiac output like we're talking about. So heart circulation problems can definitely have their vasculopaths like diabetics for sure. Dehydration, whether it's from not taking in enough fluid or fluid losses like diarrhea or vomiting. If you already have a fever, not surprisingly, it's hard to cool down. Environmental heat factors, of course. Medications, do you think of certain medications that might make it? Definitely, yeah. Antipsychotics, anticholinergics, absolutely. Beta blockers, again, anything that's going to affect your cardiac function. Just obesity in general, you've just got a lot more insulating layers that can make it harder to dissipate heat. Often when we see, not so much in Utah, but definitely in other major urban areas, raves, people taking MDMA or other stimulants and then dancing a lot and taking a lot of free water and not electrolytes and just sweating profusely. And they're all obviously euphoric and altered, may not be aware of how much they're losing. And then extreme endurance athletes, people who are overexerting themselves and potentially don't have the time or thought to stay hydrated or ability to cool off. You guys ever seen heat rash? Yeah, so this is an early form of heat illness. It's these kind of red, we call maculopapular. That means red, raised and patchy, itchy areas. It's usually under clothes because it's actually caused by blocked sweat glands. Your body's trying to sweat and the clothes are preventing it and they get obstructed. So one good thing to do is just remove people's clothing, engage people, get them in the shade, have them drink some water, maybe have them change into more loose-fitting clothing, especially if you're out on a fire or something. This happens to you or your partner. So thankfully, this is not an emergency, but it's a warning sign. Obviously, you're at risk for heat, you're getting exposed to heat, and you want to take some action. You can, but it's, again, this isn't a direct heat injury. This is more that's just blocked sweating. So honestly, not that you'd want to, but like a hot compress might actually help to unblock those pores. So something to consider, but I don't think that's not like one of the recommended treatments. It's more just letting this air out. So you could try that, but I think just a little bit of time and that more loose fitting clothing should help. Any other kind of more mild forms of heat illness you think about?
It's getting more toward
Yeah, no, so definitely nausea and that fatigue. We'll talk about kind of getting more towards heat exhaustion. Just getting that heat cramps, which is a pretty common. Yes, and this is the heat cramps and kind of exercise-induced cramps are thought to be pretty similar, if not the same thing. Usually occurs in some larger muscle groups like the thighs or calves. There's some people, it can happen during exercise or even up to a couple hours after exercise. So that's honestly more common is, you finish your long run, your long bike ride, and then that's when you get your Charlie horse. Some people think this is due to salt loss or electrolyte imbalance. That's never really been shown to be a thing. More recently, people think it's due to just neuromuscular dysfunction from fatigue, and that seems like where that exercise-induced versus heat-induced has more of an overlap. Regardless, kind of treated the same way, gentle stretching, cooling and rest. I mean, salty foods make us all feel better, and so you can try that, but it's not a ton of evidence to help. And again, warning sign, but not necessarily an emergency. So getting more into heat exhaustion, like you guys were just talking about. So this is definitely getting sicker. So nausea is one thing we look for. What else?
kind of those natural responses you mentioned earlier, like they had a breathing issue, like a little more tachypneic, and then heart rate's up a little bit as well. And they start to feel not good.
Perfect. Yeah, they're getting some warning signs, but their body's still compensating. They're have increased cardiac output, increased sympathetic activity, more tachypnic, trying to blow off some heat through respiration. They're like this person here. They're still sweating, which is one of those really important hallmarks that you mentioned earlier. That they're still able to. They've got enough volume, and their body mechanisms are allowing their body to try to compensate. They're not confused. They might be nauseous. They might be a little dizzy, but they're totally with it and oriented, able to talk to you and have that normal mental status. So those are hallmarks of that. What do you think? Is this an emergency? Is this not an emergency? How do we treat this?
Don't start taking steps now to reverse this.
Totally agree.
I think specifically like joggers or something like that, as they experience heat exhaustion, like try to cool them down, get them under the canopies that are set up and rehydrate. Because if you don't, then they're going to continue to.
Awesome. Do you have a sense of like what time frame you want to see someone start to turn around?
1 to 2 hours, I guess.
So older recommendations might have supported that, but more recently we're saying you want to be much more aggressive about it. So if someone's not feeling better in 10 to 15 minutes, they should be transported. Definitely agree with passive cooling on top of some active cooling, moisten them down, definitely get them in the shade, get some air moving over them, hydrate, all those things. If you're in a place where it's easy to transport this person, I would recommend just transporting them now. If this is more of like, like a marathon or outdoor activity like you're talking about, you're pretty far from transport. I think it's worth trying some of these, especially if it's a young, healthy person with no other risk factors and they have no signs of heat stroke, worth taking that 10 minutes to see if you can reverse things. But if they're not having a pretty rapid recovery, you want to get them moving. So heat exhaustion, what is going to get us over into heat stroke?
Oh,
Oh, yeah, sorry. What signs or symptoms? Fair enough. Sorry.
So the status here is like a sign for us. When they stop sweating, like they dry out. I would say the nausea and weakness still continues because they almost feel like sink full up type episodes. When it gets that bad. What else? So like heat exhaustion, is that what you said?
Yeah, so heat. Yeah, so we're thinking of heat illness as a spectrum. So kind of transitioning from heat exhaustion, signs that either someone's starting to develop, or when you show up, you're like, oh, this is already heat stroke. Definitely the big one. Yeah, ultra mental status, ataxia is a big one too, or just that kind of that mental status is starting to worsen. That's really the number one thing. Also, temperature over 104. If they're altered and their temp is 101, they're altered for probably different reasons. It's the heat is and fever is not helping them, but it's probably not hyperthermia that's causing their altered mental status. But if their temperature's over 104, almost definitely. You can have a temperature of 102, 103 with exertion, especially in the heat, and be totally fine. Not necessarily have heat stroke. You're probably having evidence of heat exhaustion, or at least you're at risk for heat illness. But definitely some athletes get up to that. But it's these hallmarks, these clinical signs and symptoms, either of exhaustion or stroke, we want to watch for, in addition to that temperature.
Body temperature.
Or yeah. So temporal scanners, we all know, are fraught with problems, just like oral thermometers. Especially, this is one problem when people get really dry, whether it's from sepsis, which honestly has a lot of overlap with heat stroke, or heat stroke. We know that oral thermometers really don't do a good job of capturing a true temperature when their mucous membranes are really dry. Those temporal ones, especially if they're either profusely sweating, can also not be very helpful. So we really want a core temperature. So that's, if we have the ear temperature, it's great. Esophageal or rectal probes are definitely going to be more effective. Even if you can get something up into their axilla or groin, it's going to give you more of an accurate idea. But we shouldn't necessarily be waiting for a really accurate core temperature if we're concerned for heat stroke. If they have signs or symptoms of heat stroke and you suspect it, we should just be actively cooling. And especially if they're hot to the touch, dry, red, like this patient was, and is treated accurately. All right, so how do we cool patients? What does that mean? Okay, how do we inside and outside? I love it. So what are some ways of doing that in our setting?
So removal from the areas, obviously, but we try and do as soon as we can accommodate, but like, we got the cooling packs, we can do external to, depending on the severity, right, like, to the groin, neck area, I mean, cautiously on the neck, right? So we don't make them pass out.
Yeah.
But then, removal of the excess clothes, and then once we're in the back of the ambulance, we can get like good airflow, and then, IVs is another one, so we start to head toward the internal.
Love it. Yeah. So getting them into the ambulance is number one, getting or into shade wherever you are, getting air moving over them, cool air if possible. I love the IV fluids, chilled if we have them, and then ice packs, right? These are our mainstays typically. So things have evolved a bit over time, and the mainstay of cooling now is actually ice baths, ice water immersion. There's a ton of evidence to show that this is the most effective way to cool someone. Cold water actually conducts heat 25 times faster than air, so it's very effective. You can drop core temperature about 0.2 degrees Celsius per minute, which is actually twice as fast as evaporative cooling, which is our body's most effective natural way to do it. And so this is the gold standard for caring for hyperthermia in patients. You'll see ice baths like this set up in marathons, especially in hot areas, and some areas where we see a lot of heat stroke and heat illness will have this set up in their hospitals or even EMS systems. Actually, in Phoenix, Phoenix Fire has implemented a portable ice bag. Some people call it taco technique. They don't actually fold it up like a taco, but they bring this out with their crews. So they'll put a patient in this bag, fill the bag with ice, then fill that, top it off with water and seal them up and then transport like this. It's gotten to the point they actually have those like gas station ice machines in each of their stations, and they bring these cooler of ice and cooler of ice water with them on these calls along with the bag. Phoenix is a very hot city. I think it's the hottest city in the country, and they have like 40 days over 100. I think it's over 110 or over 108 degrees a year, and so they see a ton of heat illness. At some point, this is definitely the most evidence-based, like the best way to treat these patients. As you can see, there's a decent amount of infrastructure here, especially for a large agency to add. And so we really just don't see enough extreme heat illness right now to probably justify something like this. But this is the gold standard for how we treat heat illness and heat stroke at this time. Because a lot of hospitals and a lot of EMS agencies like ourselves don't have ice bath, like we don't have this at the U, although we probably should and start going forward. The next best thing is evaporative cooling, or really multimodal cooling. So like you said, getting the patient fully undressed, definitely want to get clothes off. No matter what mode of cooling you're trying to do, clothes are going to inhibit some aspect of that. So get them fully exposed. There's some old teaching that would say put like a moistened sheet over them and then keep moistening the sheet. But that's again just going to kind of get in the way. So that's something that that yeah, I learned in residency was that wet sheet thing, but really better to just have exposed skin if you can. Ice packs are what we have at the moment, at least. And the typical, like you said, was these major, like the armpits, groin, and neck. Why is that?
Near the surface.
Yeah, totally. So we thought these are big, large vessels. There's a lot of blood traveling through them. This is going to be the best way to cool blood down. In studies, it's actually not that effective or no more effective than any other parts of the skin. But what we do know is that there are areas we really want to focus on, and that's actually the cheeks, the palms of the hands, and the soles. And the reason for that is in these major areas, you got one vein going one way and one artery going the other way, kind of two-lane street. And yes, they're big vessels, but you still have a limited surface area versus the blood flow and vasculature we have in our palms, soles, and feet, and these hairless areas in our body. It almost resembles more of a radiator. It's this like crisscrossing pattern with a lot more surface area overall. And these blood vessels have these arteriovenous connections that bypass capillaries, so they're actually able to stay open greater than other areas of our skin, like our surface, other typical like chest, back, extremities. And so they're extremely effective at dissipating heat. They also, because they don't have capillaries, don't vasoconstrict as much as our fingers or other parts of our skin as well. So we really want to prioritize those areas, the cheeks, palms, and soles, and then you can do the major vessels and then really maximize skin coverage as much as you can with ice. But we're not just doing that, right? So multimodal. So just like you said, we're still doing air conditioning. We're blowing blowing cold air across this patient. What's another way we could increase the efficacy of that cold air? Get them wet. Yeah, simulate some sweat. They can't sweat, so let's sweat for them. So you want to moisten their skin. You can use a spray bottle or like an atomizer, although that would take forever. But really just getting that skin moist. There you go. Yeah, it feels really good when you're spraying water on the back of your neck, or if you have your own water bottle. What temperature water do we want to use? That's actually, so it's an interesting point. So you might think that ice water would be better, but for the evaporative cooling, the room temperature water, because you don't have to heat it up before it evaporates, is actually better than cold water. It'll take longer to evaporate, and you might cause some vasoconstriction with like real ice cold water if you're just kind of sprinkling on them rather than submerging them. So room temperature or tepid water is what they say is going to be the most effective to maximize that evaporative cooling if you don't have them covered in ice, and then chilled IV fluids. Fluids are interesting in this setting as well. So we want to make sure that fluids are chilled as much as they can be, at least 0 to 4 degrees Celsius or 32 to 40 Fahrenheit. And if they are cooled like that, we have a ton of data from when we're trying to induce hyperthermia in patients like after cardiac arrest, neurologic injury, stuff like that. When fluids are cooled down to that temperature, we can actually drop core temperature by about 1 degree Celsius per liter. The interesting thing is that IV fluids for warming are much less effective than they are for cooling. The reason for that is because we're able to instill chilled fluid at a much bigger gradient compared to body temperature than warm fluid. So, like if we're giving 4 degrees Celsius fluid to a patient whose core temperature is 40 degrees Celsius, that's a 36 degrees Celsius change, versus we can't really give someone 150 degree temperature water when they're cold. And so because of that big gradient, and it actually works in our favor, the hotter someone is, the more effective chilled fluid is, because that gradient's even bigger. So we can give 1 liter of fluid to drop that. Really only want to do a max of about 2 liters. This says 40 cc's per kg. I'll talk about why we'll keep that at 20 cc's per kg for peds, because the problem is we don't know about their electrolyte shifts, and there's a lot of other things going on physiologically when the body's this hot. So for practical reasons, because we don't really have that much time, and for safety, we don't want to give more than 2 liters of that chilled fluid in the pre-hospital setting where we can't monitor things as closely. What do you think our temperature goal is when we're doing all these things to cool someone down? So yeah, usually like normotension is our goal in hypertension. So you think normothermia would be the goal. The problem with that is you get some rebound effect. So once you've cooled them down, their body might start kicking in and starting to put in active cooling measures as well, and you can overshoot and get hypothermic. And then you're kind of yo-yoing with this patient. So you really want to stop active cooling measures. Oh, sorry. Once we get to 39 degrees Celsius or 102 Fahrenheit, because you want to get them down to that temperature as fast as possible and then stop, because you don't want to overshoot and make them hypothermic, because they're already kind of at risk for cardiac dysrhythmias, and that rapid change can definitely make that worse. This is especially true in pediatrics. For the same reason they're at increased risk for heat stroke, they're at increased risk for overcorrection with hypothermia. It's because their surface area to mass is much higher than adults. And so they can lose heat and also gain heat much faster than we can, or than adults can. So you really got to be much more conscious of how we're treating patients, these pediatric patients, especially like really young kids and infants. They're also more susceptible to cardiac dysrhythmias and burns from skin on the ice. If you're applying ice packs directly to the skin. So we're no ice directly to the skin for infants, and just being really, really cautious of how quickly we're cooling them. A couple other questions that came out. So what about pressors, right? This patient, if we go back, was profoundly hypotensive and altered. So why wouldn't want to get his blood pressure up with epinephrine or Levophed or something?
My thought, like, because we have this cause of this reason that there's a lot of balance. So we can start to correct that, then we can have cardiac issue.
I would agree with that. Yeah. Any reason why you think you might? So there's definitely, so the pressor could address their hypertension. What else is, like, why are they hypotensive? You said you have a cause. Is it just because they're hot?
I mean, like, the reason I don't think about that immediately is like, 'cause until I can fix this one issue, right? Like,
Fair, yeah.
is that what's making my arrhythmias have these different issues? But
Yeah.
I mean, it'll be in the back.
Yeah, and if they arrest, that's a different story.
Sure.
But this person, remember this, his pressure was like 75 or 50 and his heart was 200, right? And remember, heat illness is a spectrum. So this person progressed from heat exposure to heat exhaustion to heat illness. So he's probably sweating really heavily before he developed heat stroke. And so he's probably profoundly fluid down. So that's why one reason he's so hypotensive and tachycardic. His body was trying to increase that cardiac output to dissipate heat, but now he's also just severely hypovolemic. So if you give a pressor and you have a squeeze against that heart and all those blood vessels, but there's no fluid in the pump, that pump loses its prime, and so that could be a problem. So you need to, you want to fill that tank before you apply the pressor. And again, like you said, that main problem is that hypovolemia, not necessarily the dysrhythmia or the tachycardia that's causing that hypotension. So by filling that tank, you're probably going to address that blood pressure. Another thing too is, have you ever seen a patient who's been on pressors for a week or a couple of days in the ICU? No. So one thing that happens is they get really bad peripheral constriction. So those pressors, part of the reason they work is, depending on the medication, is they cause their blood vessels to constrict. And that's going to trap heat in more than we want. We want those blood vessels to dilate to dissipate heat, right? So if you're applying a pressor, they will get vasoconstriction, which is going to kind of fight against you in terms of the thermoregulation. So definitely a good thought, and especially in a patient who's hypotensive and unresponsive, but you could definitely get yourself into trouble by using them. What about antipyretics like Tylenol or ibuprofen?
Change, right? So it's probably not going to do a whole lot.
Right. Yeah. So that's acting on the hypothalamus, and your hypothalamus is already doing everything it can to possibly prevent further hyperthermia. So not necessarily harmful, but there's not going to help in the situation. This is all environmental. What about you're out your friend's pool and someone collapses and you think they have heat stroke? Do you want to just throw them in the pool for their cold water immersion, or lake or river?
Danger of drowning.
Danger of drowning. Yeah. If you're out there in the middle of nowhere and this is going on, like, this can, it's not that it won't be effective, but you're putting an altered person into a body of water, especially if that's maybe a moving body of water or you don't know the depth of. And so unless you have a ton of support, you're definitely at risk for that person, slipping under the water, drowning, and losing them. So in a very controlled environment, and if it's all you have, it could definitely be very effective. If it's a really shallow pool, if it's cool, all that stuff can be effective, but just extreme caution and really recommended against. That's why we like the ice baths, that we know the depths can pull someone out. So for those reasons, we want to avoid these things, but definitely good things to think about. So based on that, and actually a huge shout out to Priscilla Nielsen, who caught that we had a lot of older recommendations in our protocol. She did some great research, looked at the new 2024 guidelines for heat illness and brought them to my attention. And actually, I chatted with Primary Children's, and they're also changing their protocols based on this. So thanks, Priscilla, for pointing this out. So we've updated our protocol. The biggest things here are that we do want to aggressively chill kids. It used to say, don't actively cool children and infants, but we want to treat them just as well as we treat adults, with the caveat of being really, really cautious with them, understanding that those extremes of age, they can get cold fast, and not applying ice directly to the skin. That's something that the primaries folks are pretty big about. It touches on trying to that we want to maximize skin coverage with ice, but if we don't have that, prioritizing those areas with that circulation we talked about, the cheeks, palms, and soles, followed by the groin, and then maximizing skin contact, and then the chilled fluids and the maximum amount we're given. All right. Any other questions from you guys from the field? Kept in under an hour. Stoked.
I mean, we don't have chilled fluids, and we haven't talked about we used to have chilled fluids for therapeutic hypothermia, probably at least 10, maybe 15 years ago. And so like that, that might be a question that people have is, are we going to do that in our ambulances? And probably the answer right now is no, but certainly on the table, and we have to go through a budget process to figure out what equipment we have to buy to chill.
Yeah, well, but actually, that's so this came up with the crew that brought this case up, which is an awesome thought on their part as well. And they made the point like, hey, we don't have refrigerators, but we have coolers, we have cold packs, and so if you get called on a heat illness call and it's 105 out, yeah, throw a bag of saline in the cooler on the way. There's not a ton of magic to this, so I have no problem with that, and I think that. Going back and looking at I kind of reviewed our heat stroke calls coming up to this, and again, we don't have a ton, but I think we all know it's getting hotter, and I see this becoming more of an issue. And so I think in the future, I think that's something we will definitely be looking at. A lot of things to change in our system, as we know, and we have a lot of change already, but yeah, you can get old school with it and low tech, and a lot of the other kind of search and rescue agencies, they just take a plastic tarp and a cooler full of ice when they go on a call like this, and put the person in the tarp, roll it up, fill it with ice, and just roll them back and forth, let that body temp heat melt the ice a bit, and they get their ice water that way, and that can be really effective as well. So we don't have those gas station coolers full of ice at this point, so we don't have enough to really make that effective. And but as we see this more and more, we may have to go the way of Phoenix.
So that'd be a good kind of tip, I think, on especially the hot days here in the summer, is making sure that the cooler in your apparatus is filled every morning, not just at shift change. Probably check it during the day also, depending on how cool your apparatus bay is. Refresh that ice at some point during the day.
Yeah. And every bit counts. If you open it up and it's the end of the day and it's just like an inch or two at the bottom, you can still just kind of get that on the patient's skin if you can, and that's going to be effective. You might get some weird looks currently with some of our ERs where they come in wet and everything, but if anyone who knows what they're talking about will be stoked about it.
No questions online at all?
Okay. Well, thanks for your participation, guys. I appreciate you. Yeah.
We will go ahead and end the meeting. Feel free to reach out to any of us at EMS Division with any questions you might have.
Thanks, everybody.